Stomach gets its blood supply from the celiac trunk. One branch of the celiac trunk goes to the lesser curvature of the stomach on the left side. That is called as left gastric artery. Sphenic artery goes tortuously to the spleen, but before it enters the spleen, it gives off short gastric branches and it gives off left gastroepiploic branch. And the hepatic artery, common hepatic artery, will give rise to two branches. The right gastric artery supplying the lesser curvature, and the gastroduodenal artery, which should divide into a superior pancreaticoduodenal and right gastroepiploic artery. So that is the 5 branches to the stomach. The left gastric artery, a direct branch of celiac trunk, right gastric artery branch of hepatic, right gastroepiploic artery also branch of hepatic. The short gastric and the left gastroepiploic is from sphenic artery. The lymph nodes are classified into categories. Those which drain the lymph region, spleen region, which we call as pancreatico-sphenic nodes. Those which drain from the hepatic region, then those which are branches of hepatic artery will go into hepatic nodes, and all of these nodes will finally end up in the pre-aortic, which is also called as celiac. Notice also that the lesser curvature artery are the gastric arteries, the greater curvature artery are the gastroepiploic arteries. The anastomosis between the gastrics and the gastroepiploics occur at 2/3, 1/3 junction of the stomach. 2/3 in favor of gastrics and 1/3 in favor of gastroepiploics. And these anastomosis occurs in the submucosa. So lymphatics will also follow that same way. 1/3 of the lymphatics which are towards gastric will go to those corresponding groups. Those towards the gastroepiploic will go to the other groups of lymph. Also, the anastomosis between left gastric and right gastric occur at the junction of left 2/3 and right 1/3. Remember, left gastric is a direct branch of celiac trunk, therefore it supplies 2/3 of the lesser curvature. Right gastric supplies only 1/3. Whereas gastroepiploics left and right share equal proportion of the greater curvature because both are indirect branches of celiac. And short gastric supplying the fundus will be supplied only by the sphenic branch. So we have stomach divided into multiple zones. Those in the fundic region and those in the left gastroepiploic region will drain into the pancreatico-sphenic nodes. Those in the gastroepiploic region will drain into right gastroepiploic nodes, and from there it will go into the hepatic nodes, from there it will go to the celiac nodes. From the lesser curvature, 2/3 of the region of the lesser curvature will enter directly the celiac nodes because those areas are supplied by the gastric branch, which is a direct branch of celiac. And those which are in the region of the pylorus will drain into the hepatic nodes and from there into the celiac. So effectively, all parts of the stomach will finally drain into celiac. From the celiac nodes, these lymphatics will enter the cisterna chyli, which is behind the under our right in the region of lumbar vertebrae 1 and 2. There is a cisterna chyli. From there starts the thoracic tract, which opens into the left venous angle. So the left supraclavicular node enlargement, although it seems to be lying in the neck, supraclavicular. But remember that stomach cancer can also lead to a swelling in the supraclavicular region. Similarly, the testicular cancer, which is spread to the para-aortic nodes, can also spread to the through cisterna chyli through the thoracic duct to supraclavicular lymph node. So supraclavicular lymph node enlargement is an ominous sign. It can cancer from anywhere in the abdomen, both lower limbs, left hemithorax, left upper limb, left part of head and neck. So all these areas will be examined to find out the primary source of cancer when the left supraclavicular node is attached. The right gastroepiploid node is also sometimes called as a subhepatic, subpyloric nodes. The subpyloric node will go into the hepatic. The left and right vagus supply the esophagus. By the time the vagus comes into the stomach, because of the rotation of the foregut, the left vagus becomes the anterior vagus, the right vagus becomes the posterior vagus. So left vagus goes and supplies the anterior organ, the hepatic, the liver, and the right vagus goes and forms the plexus in the celiac region. So there is a hepatic branch, which is fibers of left vagus, which has now become anterior vagal trunk, and the right vagus, which has become the posterior vagal trunk, goes and supplies, forms a plexus around the celiac artery. Before that, it has supplied the stomach. So both the branches, hepatic branch and celiac branch, will supply stomach. Vagus causes increase in acid secretion. So when there is person suffering from acidity or ulcerations due to excessive acid, there are many drugs nowadays available which reduce the acid secretion. But earlier, surgeons used to try to cut the vagus. So when you cut the main trunk of vagus, it's called as truncal vagotomy. Of course, automatically the acid will stop secreting, acidity will be reduced, ulceration will heal. But also what happens is the pylorus goes into spasm because parasympathetic of the vagus opens up pylorus. Pylorus sphincter gets closed. So what you have to do after truncal vagotomy is to repair the pyloric sphincter again to cause it to open. So that's called as pyloroplasty. So truncal vagotomy with pyloroplasty. But also what used to happen is that because you have cut the main trunk of vagus, even the peristalsis of the intestine and the secretion of pancreas and intestinal secretions are all reduced. So indigestion used to occur. Fat would not get digested, and that results in what is called as steatorrhea. Instead of all these side effects, they thought, why cut the whole of the main trunk of vagus? After the hepatic branch is given and after the celiac branch is given, then cut the vagus. That is called as selective vagotomy. So only those which are supplying the stomach is affected. So acidic secretion decreases, but digestion, etc., of the intestine does not suffer. This is called as selective vagotomy. However, the branch to the pylorus is also affected. So you have to follow it with a surgical pyloroplasty. In a selective vagotomy, what used to happen is that the posterior vagal trunk, which we said gives rise to the celiac branch. Before it gives celiac branch, it gives a branch to the fundus of the stomach, which is called as nerve of Grassi. So often when you do a selective vagotomy, the nerve of Grassi used to get spared. And that will cause supply to the fundus of the stomach, and fundus is the area which secretes maximum acid. So when you do a selective vagotomy with pyloroplasty, you have to make sure that you are cutting the nerve of Grassi, which is supplying the fundus of the stomach. Otherwise, the whole surgery will be ineffective. So we said, whether you do a truncal vagotomy or a selective vagotomy, the pylorus goes into spasm. So you have to cut the pyloric sphincter and suture it again so as to procedure allowing the gastric contents to empty. This is a surgery which is called as pyloroplasty. They found out that the left and right vagus, anterior and posterior vagal trunk, give separate branches to the body of the stomach and separate branches to the pyloric sphincter. So these are called as, those which are supplying the pyloric sphincter are called as anterior and posterior from the anterior vagal trunk and posterior vagal trunk, the nerve of lethargy. If you are doing cutting the vagus, only those which are supplying the stomach body and spare the nerves of lethargy, then the pylorus does not go into spasm. You no longer have to do a pyloroplasty. Such vagotomy is called as highly selective vagotomy. Only the fibers going to stomach body and not to the pylorus are cut off. Of course, as we said, whether you do a truncal vagotomy or selective vagotomy or highly selective vagotomy, better than any of the surgery is, of course, there are excellent anti-acidic drugs, antihistaminics, that direct proton pump inhibitors, etc., those which are preventing the acid secretion. So nowadays, all these surgeries are abandoned. But you must be aware that historically these used to be done and to give excellent results. So this is what we talked about. Although you can see that the posterior vagal trunk and anterior vagal trunk have some fibers crisscrossing each other. So when we say anterior vagal trunk, predominantly left vagus, but some fibers of right vagus also, and posterior vagal trunk predominantly right vagus, but has got some fibers of left vagus as well. And the posterior vagal trunk continues the celiac division, anterior vagal trunk continues the hepatic division, and you can see that the anterior, posterior, and there are nerves of lethargy which go straight to the pylorus. So when you cut the nerve here, it's called a truncal vagotomy. When you cut the nerve after the celiac and hepatic division, it's called selective vagotomy. If you cut only the fibers which are supplying the body of stomach and not cutting the fibers of lethargy, this is also called as crow's foot. Highly selective vagotomy. Also remember, crow's foot or goose feet are used at three places in the neck. One is the anterior and posterior nerves of lethargy, which are supplying the pylorus. The other is the parotid gland where the facial nerve comes out as nerves of, as the 5 divisions, which are also called as goose feet. And the third is anserine bursa in the knee joint. The bursa which is enclosing sartorius, semitendinosus, gracilis, and semitendinosus. So that is also looking like the goose feet or crow's feet. So these are the 3 places where you are using the word goose feet, crow's feet. So this we said is earlier was the truncal vagotomy, this is selective vagotomy, and this is highly selective. We use the word ulceration of the stomach as peptic ulcer, but remember, it is not the pepsinogen which causes the ulcer. It's not the pepsin which causes the ulcer. It is the acid, hydrochloric acid, which causes the ulcer. So the term should have been correctly called as acid ulcer. Unfortunately, it's called as peptic ulcer. Peptic ulcer can be affecting the stomach or it can affect the duodenum. So they are subdivided into gastric ulcer. Ulceration is a discontinuity of the mucosa, and duodenal ulcer. Now remember, whenever the ulcer is stretched, that causes increased pain. So person with gastric ulcer will feel pain when he eats. When he eats food that stretches the stomach, that stretches the gastric ulcer, and he'll feel extreme pain. So he'll fear eating food. In complete contrast, a person with duodenal ulcer, the moment you eat food, the food goes into the stomach, the pylorus closes, and the stomach gastric emptying stops. Because the gastric emptying stops, the duodenal ulcer, the pain will reduce. So the person with duodenal ulcer feels like eating in a short intervals so that the pain is relieved. Person with gastric ulcer fears eating. That's why a person with gastric ulcer eventually will turn out to be a very thin person because he is not eating, hardly eating anything. Whereas the person with duodenal ulcer will become fat and fat because he keeps eating after every 2 to 3 hours. So we talked about what is the relation to food intake when it comes to gastric ulcer and duodenal ulcer. And ulcer, when perforates, it results in gastric perforation. If it perforates anteriorly, it results in chemical peritonitis. Remember, it's not a bacterial peritonitis because there are no bacteria which can survive the acidic stomach. However, problems occur when the perforation, ulcer perforates posteriorly. It can affect the splenic artery, it can affect the gastroduodenal artery, it can cause pancreatitis because that's one of the stomach weight structure, and ulcers can also turn into cancer when left untreated for a long time. In pancreatitis, pancreas is supplied by the nerves which are supplying the foregut, and the referred pain is usually to the epigastrium, that is the second region of the abdomen. But because pancreas is lying on the posterior wall, the pain of the pancreas, besides epigastrium, also spreads to the back and the vertebral region of T12. So there is a radiation of pain from epigastrium to the midline in the back at T12 region. That is pancreatic pain. In contrast, gallbladder is also developed from foregut. Gallbladder pain will also be referred to the epigastrium. However, the pain radiates to the inferior angle of right scapula, which is at the vertebral level T7. So, pancreatic pain radiating to the back T12, the gallbladder pain radiating to the inferior angle of scapula at vertebral level T7. The next topic of the GI tract is intestine. The differences between small and large intestine, the differences between jejunum and liver has all been discussed. What I wanted to notice is that you have a person who has been stabbed into the abdomen, is brought to the emergency room, and you are a general surgeon. Of course, quickly you want to enter the abdomen, you do a midline incision, supraumbilical and infraumbilical, and try to find out which are the cut parts of the intestine. All the cut portions of the intestine must be cut out and removed, what is called as resection. And the other two ends of the intestine will be re-anastomosed. So, when you are doing a resection followed by re-anastomosis, remember, why can't you leave the perforated intestine as it is? Or why can't you just suture off the cut? First of all, the cut will be irregular, and when you try to suture it, some amount of intestinal contents will leak. Intestine has got large amount of bacteria in it that will cause bacterial peritonitis, which is more dangerous than what happened when the stomach was perforated, which is chemical peritonitis. So bacterial peritonitis has to be treated. You have to remove all the portions of the intestine which has been perforated. This is called resection, followed by re-anastomosis. So this is the larger lumen jejunum. You can also see the number of arterial arcs are 1 or 2. This is the smaller lumen ileum. You can see the number of arcs are 3 to 5. Of course, automatically the terminal branches will be longer in jejunum and the terminal branches will be shorter. Irrespective of whether you do it or not, remember, the portion where the mesentery is there, from where the blood vessels enter, is richly supplied with blood. The anti-mesenteric border, opposite border, has got less blood supply. So when you are doing a re-anastomosis or resection, you must make sure that no portion of the intestine will be devoid of blood supply or reduced blood supply. So If you try to take an incision obliquely like this, you will find these blood vessels are spared, but these blood vessels are not enough to resect a large portion of the antemesenteric border. So the antemesenteric border will undergo avascular necrosis, which will cause eventually perforation and peritonitis. Instead, whenever you are cutting, you should cut it in this format, that the mesenteric border is a larger area, antemesenteric border is smaller. The larger amount of blood vessels are sufficient to supply the antemesenteric border. So don't try to take a perfectly parallel incision. Try to take an incision in such a manner that the mesenteric border is larger, the antemesenteric border is smaller, so that there is no devoid of blood supply. And then you connect the end of the proximal part and the distal part and do a reanastomosis. Appendix. Lumen of the appendix in an infant is large. So whatever food enters there comes back. So there is less chance of appendicitis. The lumen of the appendix in the elderly is closed. So no food enters, no food has to come out. It is in the young adult that the lumen is small, allowing food to enter and sometimes get trapped within, which we call appendicitis. So appendicitis does not affect the extremes of age. A small child or elderly patient usually occurs in young adult age group. The morphology of appendix, we said, is a complete ring of lymphoid follicles. The pain of the appendicitis, because it's a part of the midgut, the nerve supplying it is from the sympathetic T9 to T11. The pain of the appendix is felt in the region of umbilicus. But later on, when the appendix directly touches the parietal wall, then the pain would be shifted to right iliac fossa. So initial pain of appendicitis will be restricted to umbilicus because T10 is supplied by umbilicus, T10 also supplies appendix. After the parietal wall is involved, because of the inflamed appendix, the pain shifts to the right iliac fossa. Appendix has got various positions, the 2 o'clock position, the 3 o'clock position, the 5 o'clock, 6 o'clock, 11 o'clock, 12 o'clock. Out of those positions, 2 positions are quite common. The retrocecal or 12 o'clock position and the pelvic appendix, the 5 o'clock position. These are the 2 common positions of appendix. Doesn't really matter which position is it. But before you enter the abdomen, if you know in which position the appendix, you can predict and easily resect the appendix for an appendicitis. When it comes to appendicitis, it can also mimic duodenal ulcer perforation. So care must be taken to confirm the diagnosis of appendix. Otherwise, take a McBurney incision, trying to remove the appendix and find out the appendix is normal. Suddenly you'll realize that you can't accept that incision. Go all the way up to duodenum. Another differential diagnosis for appendicitis is Meckel's diverticulitis. It's present. Meckel's diverticulum is present 2 feet from the ileocecal junction. So again, McBurney's will not help you in treating Meckel's diverticulitis. If you are unsure of the diagnosis, you have to take such an incision which will allow extension of the incision. So a midline incision is better. Then you can approach the duodenal ulcer, you can approach the Meckel's diverticulum, and you can also approach the appendix. Now suppose after you do an explorative laparotomy is cutting open and entering the abdomen. Explorative laparotomy, you find that the appendix is normal. The diagnosis is Meckel's diverticulitis, which was what was mimicking the pain. So now you have found out that it's Meckel's diverticulitis, you remove the Meckel's diverticulum and close the opening. Now the appendix is normal. Should you remove or should you not remove the normal appendix? This is always a surgical dilemma. You've already taken the consent of removing the appendix, but that was of the inflamed appendix, and your diagnosis turned out to be incorrect. So should you leave behind the appendix or not? The answer is you must remove the normal appendix also. But appendix is a vestigial organ. And even though it is, what do you say, it has got numerous lymphoid follicles, there are enough lymphoid follicles in the rest of the body as well, which will prevent the infections which will take into the body. Because if you happen to operate into the abdomen, remove the mucous abdomen, leave behind the normal appendix, and subsequently some time, maybe months, years later, he again gets the pain. Now this is truly your appendix. He has to be reoperated. Therefore, he'll sue you. You've already taken consent for removing my appendix. Why did you remove it? He has to go into another surgery. So that's why the surgical answer is that even if the appendix turns out to be normal, because you are operating on the appendicectomy, which turned out to be incorrect, you still remove the normal appendix. The mesentery of the appendix is called as mesoappendix, derived from the posterior side of the mesentery of terminal ileum, contains the appendicular artery. It is too short for the appendix. The mesoappendix is longer, the appendicular artery is short. And because the appendicular artery has to supply the appendix from the base to the tip, the short appendicular artery causes the appendix to bend on itself. The classical triad of appendicitis is pain in abdomen, vomiting, and fever. The pain shifting from umbilicus to the right iliac fossa is called as Kocher's sign or Cocker's sign. With the use of vertical incision, there is a possibility of injuring the ilioinguinal nerve. Very close to the McBurney's line is ilioinguinal nerve. So you have to take the correct oblique incision, otherwise you are likely to damage ilioinguinal nerve. Ilioinguinal nerve can also get damaged in inguinal hernia repair, but there that nerve is purely a sensory nerve and supplies the anterior 1/3 of the scrotum. That really is not a problem. But whereas the nerve when it's damaged in the McBurney's incision, that is still a mixed nerve. The motor part will go and supply the conjoint tendon. And this conjoint tendon will get paralyzed. Eventually can result in, remember the conjoint tendon is supporting the inguinal canal from the posterior wall. So this can subsequently result, maybe 6 months or a year later, as direct inguinal hernia. So we must take care not to damage the ilioinguinal nerve during appendicectomy. Atrophy of conjoint tendon and possibility of direct inguinal nerve. The 2 o'clock position is called as pre-ilial or post-ilial, depending on whether it is in front of the small hemisphere or large behind. Promontoric, sub-ilial, pelvic 4 o'clock, 5 o'clock, subcecal 6 o'clock. All these positions together are called as the anterior positions. Posterior position is 11 o'clock paracecal or posteriorly 12 o'clock retrocecal. Out of which we said the pelvic and the retrocecal account for 99% of the positions in the appendix. Which position is the commonest? Wakeley et al. In 1933 did the positions of appendix in 10,000 patients. And he found out that the retrocecal is the commonest. 2/3 of the cases are retrocecal, only 1/3 is pelvic. One has to be careful was O'Connor and Reed in 1932, 1 year before Wakeley, had studied 3,750 cases of appendix. And he said, pelvic is commonest, 2/3 of the cases are pelvic, 1/3 is retrocecal. So we have to really be guarded. What would be the position of the appendix commonest, pelvic or retrocecal? Because Wakeley et al. 1933 studied 10,000 cases, that is considered as the commonest, whatever are his findings, the retrocecal. Can you test which position in the appendix before you operate? There is a test called a Psoas test, and there is a test called an obturator test. Right psoas muscle test, where the appendix is in a retrocecal position. Forced extension and lateral rotation of the right thigh produces increased pain in the right lower quadrant of the abdomen. Extension and lateral rotation of the thigh is the opposite action of psoas major, right psoas major muscle. So by stretching the right psoas major muscle, if the appendix is in the right retrocecal position, it's resting on the psoas muscle. It has got irritation of the psoas muscle. Forcible opposite action of psoas will cause increase in pain. Whereas if the pelvis is if the appendix is in pelvic position, it will irritate and cause spasm of the obturator muscle, obturator internus. Do the action opposite of what obturator internus will do, flexion and medial rotation of the right thigh. And that produces the increased pain in the right lower quadrant of the abdomen. The appendix is in the pelvic position. So extend lateral rotate thigh, flex medial rotate thigh. Find out which increase the pain more severely. That will tell you whether the appendix, if the psoas is irritated, the psoas test will be positive, appendix is retrocecal. Obturator muscle is irritated, obturator goes into spasm, obturator test positive, appendix is the pelvic region. Really, it does not matter. If you have to enter the abdomen, you can always find out whatever be the position, you can remove the appendix. There's something called as rebound tenderness. Deeply press upon the right iliac fossa, deeply but gently press the right iliac fossa. There is some degree of increased pain. Suddenly leave the pressure. The wall will come back anteriorly, appendix will come back anteriorly and hit the anterior abdominal wall, severely increasing the pain. That is called as rebound tenderness. So you have pressed upon the right iliac fossa, you are gently pressing upon it, but suddenly leaving it causes the rebound, increased pain. It's called rebound tenderness. This will tell you exactly that the appendix is in the right iliac fossa. Because in a person who has got situs inversus, the appendix will and the liver, the appendix will go to the left side, the liver will also the left side, etc. Your right backward incision is completely useless because the appendix is the opposite side of the body. And remember, you can't make out. Umbilical pain will be common in both, and you're operating on it. So you have to test for rebound tenderness to confirm that the appendix is where it is. Also, the appendix can be in the subhepatic position. If it is the subhepatic position, there will be no rebound tenderness in the iliac fossa. It will be a rebound tenderness in the hypogastric region. So, before you take a backward incision, which is not capable of being extended extensively to reach the organ, you have to confirm while ensuring that the position of the appendix is in the. There is also something called as Robsing sign. You apply pressure in the left iliac fossa, then gently keep on pressing from left iliac fossa upwards to the left hypogastrium. Not the hypogastrium, left lumbar region, then left upper abdomen. Then from there you go to the epigastrium to the right subcostal region, then right lumbar region, then come to the right iliac fossa. So you are going in an inverted U-shaped manner. From left iliac fossa, you are going to left lumbar region, left hypochondriac region. From there to the epigastrium, right hypochondriac, etc. When you keep on pressing in that direction of the inverted U shape, the pain will increase because the gas in the left iliac fossa, there is a descending colon. The descending colon gas will be pushed to the transverse colon. The transverse colon gas will be pushed to the ascending colon. Ascending colon gas will be pushed to the cecum, and from there into the appendix, the pain will increase. So Romsing signs starts from the left iliac fossa, goes in an inverted U-shaped manner to the right iliac fossa. The exact function of appendix is not known, apart from the fact that it has got a lot of lymphoid follicles, but that really doesn't serve much purpose because food does not normally enter the appendix. Probably in lower animals who are herbivores, they help with digestion of cellulose. In humans, cellulose is not digested. It is passed off as feces. The fiber in the diet does not get digested. So as we said, appendix performs the immune system function, but still that does not mean that a normal appendix should not be removed in an exploratory or diagnostic laboratory. Double negatives, which means you must remove even a normal appendix when you are entering the abdomen. Okay? Even though it's a part of the appendix, we said it really doesn't serve as much of an important immune organ. So you must remove even a normal appendix. You must not leave behind even a normal appendix. Which is why they said appendix is the only organ in the body that has no anatomy, only applied anatomy. The next organ that we are studying is the liver. Liver is divided into 8 segments. These 8 segments are important to know because of segmental resection. Point to be remembered, segment number 1 is called as caudate lobe. 2, 3, 4 are 2 is left upper lobe, 3 is left lower lobe, 4 is quadrate lobe. So 1, 2, 3, 4 are the left lobes. 5, 6, 7, 8. 5 is lower anterior, 6 is lower posterior, 7 is upper posterior, 8 is upper anterior. Remember, all the 8 segments are in sequence. 1, 2, 3, 4 are on the left side. Caudate, left lobe, quadrate. 5, 6, 7, 8. Anterior lower, posterior upper, anterior upper, right side. Notice that there are 3 major hepatic veins. One draining from the left lobe, one draining from the right lobe, and one in between draining from the medial aspects of the right and left lobes both. So basically, right hepatic vein, left hepatic vein drains from the medial lobe, and the middle hepatic vein or the central hepatic vein drains from both the lobes. Also, the portal vein hepatic artery divides into right and left division, which are equal size because 4 segments on the left side are supplied by the left hepatic vein. 4 segments on the right side are supplied by the right hepatic vein. Care must be taken to realize that the segment number 1, the caudate lobe, has got a branch from the right hepatic artery as well as the left hepatic artery. Both the hepatic arteries and the portal vein will supply caudate lobe. So we are doing a resection, especially when it comes to donating part of the liver to a person who got liver failure. You do not tamper with the caudate lobe because of double blood supply. You can safely remove the segment of the 2, 3 and give that to the recipient. The space below the diaphragm is called subphrenic space. It has been divided, this is the anterior, this is posterior. On the right side, it has been divided by the liver to right suprahepatic space and right subhepatic space. Okay, above the liver and below the liver. And in between the suprahepatic space and subhepatic space behind, there is an extraperitoneal space on the right side. It is also called as right anterior subphrenic space, right posterior subphrenic space, and right extraperitoneal space. On the left side, there is only a small part of the liver, but a big part of the stomach. So the part in front of the stomach, whether it is above the liver or below the liver, both are considered as anterior subphrenic. And the posterior subphrenic space on the left side is the lesser sac. Between the stomach, the pancreas, left kidney, that and the suprarenal. So the space between the suprahepatic and subhepatic. This subhepatic is incorrect. This is called as anterior and posterior. Both are parts of anterior subphrenic space, left anterior space. Because left posterior subphrenic space is a lesser space. And the space between the subphrenic and the subhepatic is the extraperitoneal left subphrenic space. So there are 6 subphrenic spaces: right anterior, right posterior, left anterior, left posterior. Left posterior is lesser sac, and right and left extraperitoneal spaces. The left intrahepatic space will be divided into a smaller antegastric space and a larger lesser sac. On the right, over the bare area of the liver, outlined by falciform ligament, coronary, and triangular ligaments, is the right extraperitoneal subphrenic spaces. On the left, this is bounded by distal pancreas, descending colon, upper pole of left kidney, left adrenals, and Gerota's perineal fascia. This is the fascia, continuation of fascia transversalis, which enclose the left kidney, and the fat are related to the left extraperitoneal subphrenic. Infection of these areas will result in pus accumulation in the extraperitoneal spaces. So we already discussed that the 2 portal triads and 2 hepatic veins form a diamond-shaped area, which is called as hepatic acids. Cause the nourishment, both venous, portal venous, and hepatic artery. Nourishment comes from the central part of this acids and spreads to the central vein on both sides. Deficiency of substances in the diet will affect the area zone 3 most, because zone 1 will eat away most of the essential nutrients. So when there is lack or deficiency or reduced consumption of essential amino acids, they will be taken up by the zone 1. But zone 1 is equally affecting the toxins also. Toxins will affect zone 1 most. So that's why the toxins are first. Zone 3 are least affected. Also, the oxygenation, hypoxia, will affect zone 3 earlier, because zone 1 will take up whatever oxygen comes from the hepatic artery. This is the zone 1 around the hepatic artery portal vein, zone 2 a little further away, zone 3 close to the hepatic venule, the central vein, also called. gallbladder, fundus, the neck. And look at between the body and the cystic duct. There's a depression called a Hartmann's pouch. Hartmann's pouch is where silent gallstones are located. When the gallbladder concentrates bile, if it crystallizes to form gallstones, and the gallstones will get located in the Hartmann's pouch. You should not block the flow of the bile. So silent gallstones are located in the Hartmann's pouch. It will be diagnosed quite late after the stones are large and completely obstruct the system. Whereas earlier spread of gallstones into the cystic duct or common bile duct or even at the obturator will cause inflammation of the gallbladder, which is called as cholecystitis. If the stone is located in the obturator, not only will there be cholecystitis, but because of the pressure of the pancreatic duct, it will also cause pancreatitis. So cholecystitis, pancreatitis together occur when the gallstone is located in the apula. Only cholecystitis when it is located in the common bile duct or cystic duct, and silent when a small stone is located in the Hartmann's pouch. Jean-Francois Calot described a triangular region here called as Calot's triangle. What are the boundaries of Calot's triangle? Cystic duct, common and right hepatic duct, and the inferior surface of the. This is the common hepatic artery, and this is the right hepatic artery proper. This is divided into right hepatic artery and left hepatic artery. This is cystic duct. Right hepatic artery gives a branch to the gallbladder, which is called a cystic. Remember the word cyst, it's a bladder. We have not specified whether it's urinary bladder or gallbladder. The artery to the gallbladder is called cystic artery. The artery to the urinary bladder is called as vesical artery. But when we say cystitis, it means inflammation of urinary bladder. For gallbladder inflammation, we have to call it as cholecystitis. Chole means bile. So bile bladder cystitis. What Jean-Francois Calot did was he said that the right hepatic, so he said what are the boundaries? Cystic duct, common and right hepatic duct, and inferior surface of the duct. What Calot described was that the cystic artery and the cystic duct are almost at right angles to each other. So when you are removing the gallbladder, you have to tie the cystic artery as well as the cystic duct. He said, do not tie cystic artery and the cystic duct by a common ligature. If you tie it by a common ligature, chances are one of the two of them may slip. So that was a very important surgical principle. Cystic artery and vein can be tied together because they are parallel to each other. Cystic vessels, cystic duct should not be tied with a common ligature. This is what this caused the triangle to be named after Calot, Calot's triangle. Remember, in that 18th century, Calot did not describe these as the boundaries of the triangle. He described cystic artery, common and right hepatic duct. He described only common hepatic duct, and he described the third boundary, cystic duct, common hepatic duct, and cystic artery. This was the triangle which Calot described. But because cystic artery is highly variable, and yet to give credit to Calot, we have changed the third boundary, cystic duct, common and right hepatic duct, and inferior surface of liver. There are some surgeons who have read history. They say, no. Calot's triangle is cystic duct, common hepatic duct, and cystic artery. And that triangle which we now describe cystic duct, common and right hepatic duct, and inferior surface of liver, they say is called a cystohepatic triangle. There is a slight difference between cysto-hepatic triangle and callous triangle. For our understanding, we say cysto-hepatic triangle of callus. We'll stop at this particular point because it's nearing 10 o'clock and you have to proceed to the section hall soon. Any questions you have so far? This is the site of motor systemic anastomosis. We'll discuss in greater details in the third class on applied anatomy. You can mark your attendance in the chat box and proceed to the resection hall. If you have any questions, you can ask now.